Welcome to Friends with Fertility, the podcast where we dive deep into the world of fertility, reproductive health, and all the emotional journeys that are in between. I'm your host, Elizabeth King, a fertility expert dedicated to providing you with the knowledge, support, and inspiration you need on your path to parenthood. Whether you're just starting out, exploring your options, or looking for solidarity and advice, we are here for you. Let's embark on this journey together and turn uncertainty into empowerment and make friends with fertility. Let's get started. Hey everyone, welcome to Friends with Fertility. Today we have Dr. Uliana Dorofeyeva. I did my best there. She is a consultant at IFG. She is an IVF specialist, a distinguished authority in the realm of assisted reproductive technology, which is ART, focused on avant-garde fertility treatments like groundbreaking mitochondrial donation. With a wealth of expertise, she excels in diverse facets of reproductive medicine, including advanced ovarian stimulation, tailored solutions for low responders, meticulous evaluation and magnetic management of oocyte donor cycles, expert handling of embryo transfers, reproductive endocrinology, and surrogacy. So, welcome so much, Dr. Uliana. Thank you for being here.
Thank you, dear Elizabeth. It's my pleasure.
I feel like from that bio and saying everything that you do, this could be like 4 series of podcasts just alone for you to educate us on all those amazing things that you do. But let's start with the mitochondrial. It's something that I find very interesting and fascinating. People know that I really like to get into the science of things. What is mitochondria and why is it important for people who are going down reproductive technologies?
Yeah, that's a great question. And thank you for starting from here because we need to start with the energy. And the mitochondria is known as the powerhouse of the cell, and it produces most of the energy our body needs for all the organs, for all the systems, for all the processes which are happening in our body, as the fertilization and the embryo development is just one of those processes which also needs a lot of energy, and that should be the right energy, like really powerful, really stable. And it's not only about the energy, it's also about the molecular processes, biochemical processes, metabolic processes, intracellular communication, and so on and so far. And what is interesting to mention or important to mention is that we can be young and we may face issues with the mitochondria and the energy production, or we may become older and this is obvious that in that period of time we are getting older and our powerhouses are almost empty or they are not fully functioning and they will not be able to provide us with as many energy as we need for all those important processes.
Which is fascinating because I think I had children over 40, and that's a big thing. My doctor said, "You're 30, you have 30-year-old eggs. You have 40-year-old eggs." Not really saying that the mitochondria of those eggs is really what's fueling the makeup of whether it's good or bad. Quality is good or bad based on the mitochondria health of the egg. So can you tell us about that and why it's important that the health of the mitochondria is so impactful to the quality of the egg and therefore the quality of the embryo?
So, in order to understand this, or to just make it simpler, it's easy to illustrate the oocyte as a very big cell in our body, which has obviously two structures, or we may divide it into main two structures. One, which is very important, which is the nuclear DNA, where all the genetic information is coded. Actually, this is 99.9% of the genetic information, because also oocyte has the external environment, which is the cytoplasma, and this is quite a big portion of the cytoplasma. And inside the cytoplasma, we are having mitochondria. This is one of the important factors. We consider this as the one of the most important factors. However, we are still learning about this environment, and this may happen that it's not the only one. However, it's definitely the most learned about. So we know already about mitochondria, we know about its circular DNA, We know that it has 37 genes, and that's why the babies, or the whole technique which allows the mitochondrial replacement therapies, they are called three parent DNA. And this is something what is making patients scary about the future of this technique, about the long lasting effects and the overall health of the babies, and so on and so far. However, we need to understand that the nuclear DNA is this is the whole genome, which is, and we are performing testing of the embryos, which we are going to transfer to the patients. First, we want to be sure that they are healthy, meaning we are performing PGTA testing, and we know that this is euploid embryo. And second, we are able, and we do this, we perform maternal testing, maternal matching. So we are taking the genetic material from the mother and the embryo, and we match them both. And the highest percentage of the third DNA from the donor, which was in the embryo, it was less than 0.1%. So this
Right.
also shows the fact that this is very important change, which is like changing this environment, meaning we reconstruct the oocyte or we reconstruct the zygote, depending when we are going to transfer the DNA from the patient oocyte into the cytoplasmic environment of the donor, either embryo or the zygote. This may happen either in day zero or day one, and these are two different techniques. However, the results are very similar in terms of the success rate, in terms of the technology process, and so on. So that's why it is really important, and we see totally different outcome compared to the regular IVF treatment and the outcome after the mitochondrial replacement therapy in terms of blastocyst number and the percentage as an outcome from egg to blastocyst, and the euploid blastocyst rate, which is the most important.
So I have so many questions on this, but we wrote down some questions prior, and I'm going to stick to that script and then go back if we can. So, how do you explain how mitochondrial donation works in practical terms? How does it differ from traditional IVF treatments?
So, for the regular IVF, we are stimulating a patient. We retrieve the oocytes from the mother, we fertilize them with the sperm, and implant the resulting embryos back into mother's uterus. In the mitochondrial donation, the process involves taking the mother egg, removing the nuclear DNA, and transfer it into the donor oocyte cytoplasma. This donor oocyte environment contains healthy and active mitochondria, as we already mentioned, and also molecular mechanism and intracellular communication, biochemical, metabolic processes. They all work as in accordance with the young and healthy environment. And donors who are mitochondrial donors, they are proven donors, and this is also a very important factor because oocyte donor may provide us with 30% blastocyst or 90% blastocyst, and this is very known fact. So those who are mitochondrial donors, they have been donating their eggs before, and we know their performances, we know their outcome, their blastulation rate, their euploid blastocyst rate. They are mothers on their own, meaning they have their own kids, because not all of the mitochondrial diseases can be detected, unfortunately, right now. So
Right.
even in the extended genetic testing panels, we don't have all the 37 genes. And sometimes this is just a very bad luck knowing about this while the baby is born. So that's why
Right.
this is very important part of the treatment, to select the mitochondrial donor right. From another side, we don't have, and we are working right now on the mechanism how to test the mitochondrial activity and the overall environmental activity of the follicle and also an egg. Because that's true that not every patient over 40 will have critically low blastocyst outcome or critically low euploid blastocyst outcome. Also, this partially true. We have seen some patients who have quite high blastocyst rate, but still lower euploid blastocyst rate. But numbers matter. If they have a really good blastocyst outcome and good ovarian reserve, or relatively good for patients in over 40, they are still a good candidate and they can repeat their IVF treatments with aim or with the expectation of receiving about 10% or maybe maximum to 15% euploid blastocyst. And if they will have 10 embryos in total, they can accumulate this over several stimulation rounds. They will be lucky to have euploid embryo. But if this is a patient who also uh, has a reduced ovarian reserve and hardly can provide us with one or few oocytes in a round, that should be probably a patient for whom this treatment, as the advanced treatment of mitochondrial replacement therapy, should be suggested because we are limited in numbers. We would like to give the best potential to each oocyte and each nuclear DNA which we may find from the patient to develop in the best conditions.
And what type of fertility issues or genetic conditions can mitochondrial donation address other than that fertility treatments can't?
So, mitochondrial replacement therapy is particularly effective for women who have age related fertility issues. However, this is not number one, and we always need to have a medical indications for this treatment. And the medical indications are repeated at least 3 cycles with either having no blastocyst created in the IVF round or no euploid blastocyst, again in the multiple cycles, at least three. And
Why
the
do you
this
do 3?
it's like something to understand it's repeatedly. Of course, we may consider if the patient had less rounds. However, from our practice, we usually see patients with many more, not even three, but 5, 7, 11, 17, and so on.
Wow.
So they are trying and
Mhm.
trying, and only if they already have no hope, they are, because the alternative for the regular IVF, usually all those patients we are consulting or who are looking for this treatment, they have been recommended to use oocyte donation. And oocyte
Mhm.
donation is an effective alternative, of course. And until the mitochondrial replacement therapy as a treatment was developed, that was the only alternative. And
Mhm.
I've been, since I started in 2008, I've been consulting many, many patients. And most of them, they were advanced maternal age patients, those who were looking for the oocyte donation. And I had no other option either to tell them to show them the percentage and the probability of using their own eggs to continue and how many rounds. It was always a dilemma. Either we
Right.
should tell to the patient, you should try one more time, and for how long, how many one more time that could be, or
Right.
something what is reasonable, or you need to switch to the oocyte donation. However, here, emotionally, psychologically, it was very hard because women understand that they will have no genetic relation with their baby, and that was
Right.
really hard to accept. And now and frankly speaking, that was the motivation for us, for our team, to start talking about this treatment, because we've seen our patients being successful, and we had patients who were lawyers even, and they were saying, like, if you have this treatment, you have results, you need to tell this information to the patient under the informative consent. And then the patient, after having all risks and benefits, would decide what will be her optimal treatment. So now we are saying we have 3 opportunities for patients who are advanced maternal age patients: either to continue doing regular IVF with the expectation from zero point 0.3 to 10 or
Right.
15% of their success, or
Mhm.
to switch to the oocyte donation, where we know that the baby genetically will not be related to the couple or to women at least, or to switch to the mitochondrial replacement therapy, which still is an innovative technique, but it already shown as being effective, as being safe, because we have so many kids born, and the oldest kid will be 12 soon, and we have many kids which are aged 6, 7, and less than this. So of course we need to monitor. It's too early to talk about the long term effect. However, we all, as the whole society, we were checking the health status and the life conditions of Louisa Brown, and we were so happy to see that her
Mhm.
fertility is natural and everything is great there. So
Right.
it's just the innovation and the development, technological development in this sphere.
Even in, regular ART, IVF, and all of that, it blows my mind every day that this is possible in the world we live in. this is now taking it to a different level of this is amazing. I get goosebumps in my skin to think that this is possible for us, for people to have this. What an incredible opportunity as an alternative, like you said, of something else now that science is moving towards. I think it's really fascinating. Can you share patient success stories that highlight the impact of mitochondrial donation?
So we had patients who are young and healthy on their own, but just they were lucky to know that they are mitochondrial disease carriers, and they requested this treatment in order not to transmit this disease into their further generations. And this is the one of the most important medical indication for this treatment.
Right.
And this is how this treatment is allowed in the UK since 2016, and in Australia and New Zealand since 2022. Just, of course, it's not like for this kind of diseases, for mitochondrial genetic diseases. And this is a lovely couple. They have already two kids in their family. And the patient, she was 33 when she started with us, and that was 3 years ago, and they are like a long term with us already.
Mm.
So she's pregnant with the third child. So soon there will be, and that's the biggest family so far in our
Yeah,
history. The one who will
amazing.
soon have, she ended already the first trimester. So that's very,
Oh,
very
congrats.
successful. You know,
That
we're always
that's
talking about
significant.
the first success is to create diploid embryo. Then the
Right,
second milestone is to get an implantation test. So
mhm,
positive HCG, then the heartbeat, then to pass the first trimester, and then the second and the third usually are quite easy, and then the delivery itself and the live birth. That's
right,
the whole story. So she's
right,
the one, she's very warm for us. And then probably the case which I remember very well of 47. So the
mm,
lady, she's from UK. She was 47. Then she produced her eggs, and we were able to get. We had multiple stimulation rounds for her, and we were able to get from her only two eggs. And out of
mhm,
those two eggs, we had one which became euploid blastocyst, and we transferred, and it's implanted. And she also delivered a baby once already. She was 48. So this is
wow,
something when I thought it's already, you know, we were thinking, we were discussing, should we discuss or think about any age limit, like should we
mm,
treat patients over 45,
right,
or is, because in many countries there is an age limit related to the
correct,
regulations in the country, and those regulations in the country, they are the ones which force patients to travel globally. They need to
right.
travel because they cannot get a different kind of treatment, oocyte donation, stem cell treatment, which is quite important now, and this is also gives a hope that's at different level as well, and surrogacy and so on so far. Yeah, so
That's
that's
amazing. How is the actual process like? So if for the donor, how does that look like for the donor? If somebody says, I can donate my mitochondria, is it the same as doing an egg retrieval? What's that like for them?
Yeah, for them, this is the same process as being an oocyte donor, because, like, we internally we call them mitochondrial donors of mitochondrial treatment. However, they before they become donors for mitochondrial replacement therapy, they were regular donors because, as I said, this is very important to know their proven fertility by
Right,
having kids on their own, and also their potential of the created blastocyst and the euploid blastocyst, and also morphology of their oocyte and their development during the embryo development stage. What also important that their oocytes should be fresh. We, you
okay,
know, with the development of the oocyte vitrification, we used to tell that there is no difference for either you are using fresh materials or vitrified, because the survival rate is almost 100%, and there is no impact of this process compared to the slow freezing into the further conditions of the materials. However, again, for the mitochondrial replacement therapy, because of those molecular intracellular communication and other factors which are so important in this process, we still use fresh oocytes. So Donors are synchronized with the patient's
Okay.
cycles. It's not possible in 100% for all to be synchronized. That's why patient materials can be vitrified either as an egg or as a zygote. And for some cases, we work also with clinics overseas, which may vitrify either eggs or zygotes and then send them to our clinical location where we will process the mitochondrial replacement therapy. Donors are also flying there, and we have a day or two or several when we do the entire process, the replacement. We decide.
So you're literally taking the eggs out of the donor and then extracting the mitochondria from the egg
mm,
and then putting it into, am I understanding that correctly?
Yes, but we are taking an egg from the patient. We extract this spindle, which is the nuclear DNA, and then we
Mhm.
transfer this spindle into the enucleated oocyte from the donor. This is called spindle transfer, and this is performed on day zero, just immediately after oocyte collection and the denudation. This process
Okay.
is recommended for those patients who either have fertilization arrest before the morphology of their oocyte is very, very poor, and there is a risk that their oocyte will not be fertilized, so they will not make a zygote. For this is minority of the cases. Majority of the cases, we are extracting an egg. They are called pronuclear transfer. So we extract the egg from the patient, extract the egg from the donor, fertilized both cohorts, patient oocyte and the donor oocyte with the partner sperm, and leave them for fertilization. After 16 hours post fertilization, we are taking them out from the incubator, and the embryologist is replacing two pronucleuses, which are making, like we see both pronucleuses. It shows that the fertilization is completed. Then we are taking the pronucleuses from the donor zygotes, throwing them away. And instead of those pronucleuses, we are inputting pronucleuses from the zygote which developed in the patient oocyte. And then the development of the embryo continues as usually until the blastocyst stage. So we need to mention that what patients sometimes they are thinking, if we are just injecting part of the cytoplasma of the
Mhm.
young and healthy donor into the zygote or the oocyte from the patient, this is called cytoplasmic transfer, and this technology showed to be not successful because it's
Okay.
not only about particles of the cell, it's about the overall environment. And that's why we are saying that probably not only mitochondria plays the role, but there is more factors there which we are currently investigating.
Okay. It blows my mind. I am speechless that you guys are so innovative in this realm, and I think it's amazing. Let me go back to say the reason how we connected with Dr. Uliana is I was in Amsterdam for ESRE for the Fertility Care Awards, and they received an award for the innovation of what it is that they're doing at their clinic. So, of course, we reached out for Friends with Fertility to have this conversation because I think it is so important to people to have an awareness that there's another option and this science is happening and it's successful and it may be an opportunity for you to consider if you're going down the road of IVF and considering maybe you have been told that you need an egg donor and you're not quite sure that that's what you want to do. This could be an alternative to that. Um, what type of advice would you give to couples or individuals considering mitochondrial donation or other advanced fertility treatments?
So my advice is to stay open to new possibilities and not to give up hope, even if you are facing challenges or you have faced them in the past. Fertility treatments have advanced significantly right now, and there is always, every day, every week, there is something new. And if you are following the innovations and you are strong and creative and knowledgeable enough to give a trial for this, of course, safety is first, but then it works. I recommend to consult with the fertility specialist to explore all available options and not to hesitate to ask questions about how the new techniques can address the unique situation of each individual or each patient. The journey may be difficult, but there is always a hope and the positive outcome.
I agree. I feel like where there's hope, there's possibility. and don't give up hope on what it is that you are driving towards, because if it's to build your family, there's a lot of options right now, and it may not look what you thought it would look like initially, but we live in a day right now in this world that a lot is possible. And to reach out to Dr. Uliana and her colleagues to see if you might be a candidate for that. Let us, our listeners, let us know where you are located so that we can find you. You're in Eastern Europe, correct?
Yes, the of the regulations in this for these treatments, we are practicing. The main location for the mitochondrial replacement therapy is Albania. This is the country where, in the law, the experimental treatments are allowed, and patients are signing the consent as a part of their all agreements and the consents for regular IVF. We may also perform this treatment in Ukraine. However, we all know that the challenges we are facing there, and Georgia is the country where this can be performed. However, for many patients, we are working in the collaboration with local clinics, depending where they are, if clinics are willing to cooperate. However, for last 3 years, we see more and more clinics and individual professionals to be open to this opportunity. What they are doing, they are just stimulating a patient, because for advanced maternal age patients, quite often there is a challenging practice to stimulate them, because if this is an advanced maternal age patient and with the relatively high ovarian reserve, what I'm happy with, at least zero point 0.5 and up. However, many of our patients, they are less than that, and what we are doing, we are very creative and innovative in terms of the IVF treatment and the stimulations as well. We are using a lot of random start, all follicular waves. Like, we do not stick to the regular IVF, meaning just in standard start on day 2 and use the only like the short protocol with the typical doses and the typical add-ons, or without add-ons. So we are trying different things. For many patients, we use exosomal treatment and the PRP treatment, or the combination of both, or the stem cell treatment, in order to boost their follicular production a little bit. And then the cooperation with the patient, I should say, is also very important, because they need to prioritize this treatment, because it's not always everything will go as under the plan. If this is the priority, then patient would need to change plans. We are quite flexible, and we are trying to be in touch 24/7, because patients are from different continents, starting from the US and Canada and ending up with Australia. And most of our team is in Central European time. So we are managing the communication and the cooperation, either with individual patients or the clinics. However, as I said, the openness to the opportunities of collaboration and the innovations, and prioritizing and believing in the things which maybe never tried, but there is all the criterias are showing that we need to try and we potentially may be successful, we will always tell yes to such patients.
Well, I am so fascinated and honored to speak with you. I think what you all are doing is incredible and so exciting to see how everything is evolving in this direction. And as you were speaking right now, it reminds me of my friend who is the first IVF baby in the United States and how far it's come, right? And you are at the beginning stages of this new evolution of what is to come. And it might be a little scary at first because it's new technology, but at the same time, it's happening. And if it's something in your heart that you're after, a plane ride away or starting with a phone call to the clinic to see what that might look like for you is a good place to start. And I'm really thankful for you to be here. I know it's quite scientific for the conversation. And if any of you have questions about how to break this down and what it means, please reach out to us. And where can they find you, Dr. Uliana? Do you have a website that we can point people to?
Yes, that's the International Fertility Group website, ifgivf.com. You can find us through all the social medias like the LinkedIn, Instagram, Facebook. So we are very open, and I believe you will be able to reach us. So, yes, do not hesitate to ask questions. We do a lot of individual consultations with our patients. We know that, and initially we communicate online. For many patients, we meet each other just for the day of the egg retrieval, the first time. However, until that happens, we know already a lot about each other.
Right.
So this is like online communication and consultation. So we are open for this, of course, always. We do a lot of educational events. So also follow up about this because we believe that this is very important. This is how we learned about the new opportunities, how we are proving about the safety of this. We do a lot of scientific work right now. We are still collecting more information. However, very soon we believe we will publish very exciting data about the results and what we may found or what we may think about is playing the role because the whole society is moving that direction. Patients are getting older. And from one side, we are educating patients that we need to freeze our potential, like to freeze the egg. And if you will ask me, when to freeze the egg, I would answer until you have them. If you have them,
Mm.
if you are 45 and you have been PCOS patient for the whole time, and I've seen patients in my maximum number of retrieved oocytes for patient in 45 was 28. And this is wonderful result. So
Wow.
and
That is.
yeah, but she's PCOS, and her family menstruated. Her mom and the grandmom, they had periods until they were 59. This is
Wow.
something which is genetics, but this is an individual case. Like the average for all other patients would be somewhere in between 3 to 5, I would say. And for many patients that will be much much lower. So this is very individual treatment, and patients sometimes they are asking like what will be the probability for me. I am 43. I cannot tell this until I
Right.
will receive antral follicle
Right.
count, IMH, IFC, FSH, previous histories of the IVFs, if they were like a lot of information is needed in order to evaluate the patient. And after that,
Mhm.
still we need to try because, as I said, we are using different protocols. We are monitoring things which not always are monitored because quite often patients are coming from the countries where insurance is covering the treatment. And this again regulates them a lot because they are doing very standard things. But
Right.
it's not always working to do the standard things. You need to
Right.
think out the box in order to get something different. So there is always
And
hope.
to that point, I think from being in America, there is quite standard regulations. And what I have seen with working with people in 21 countries around the world, there is different regulations in different countries. And so it is really nice to have, even if it's a phone consult with someone in Europe, to say, what protocol would you recommend for me at my age? Because it will be different than the protocol that someone in the US has given you, mainly because that's what we've done and we don't have as much flexibility in that way. The medications will probably still be the same, but the amount of drugs and the specifically will be different. And I think I love that you point out you need to do it for your individual being because everybody's different, which is why, one of the downsides of social media because they see, oh, Elizabeth had 3 children over 41. Yeah, but that's my story. That might be different for somebody else. And everybody knows that they have different things. So I have thyroid disease. I have different things, and so you can't compare yourself to someone else. Once you get the education for your own body and your own family, then you can make a decision for you. It doesn't matter what somebody else does because that's not your body and your so it's really really don't waste the time looking up the results for other people your age or younger or older. What you really want to do is just get yourself there and figure out what the makeup of your own DNA and genetic makeup is so that you can make an educated decision of how to build your family.
I totally agree, Elizabeth. Thank you for such a great sum up.
Thank you for being here. I'm really, really for people to have this as an option, especially being an older advanced maternal age person myself, it really is going to open the doors for a lot of women across the world. So I'm very excited. Thank you for being here.
Thank you, Elizabeth, and it's a pleasure. We still have a lot of topics still to discuss, but I believe that that was the most important. And I appreciate the fact that you're bringing this awareness about this technology. It's not easy to be a pioneer, and we've seen a lot of like not understanding the process or trying to ask critical questions. Yes, we cannot answer all the questions right now, but we see the data and we know this process works. And to stop with the numbers, like there is a nuclear DNA impact on the age of the patient. But what we used to measure, this is the aneuploidity rate on the embryo. We haven't been measuring the potential of the oocyte to be euploid or non-euploid, or even potential of the nuclear DNA to be euploid or non-euploid in the beginning of this process, because during the process there is a mechanism which is called the self-correctness, and if we know how to turn on the self-correctness mechanism, then we are reducing again this percentage of abnormal nuclear conditions, and we can turn on the clock or to turn
That's
around the
amazing. I
clock.
I get so excited. My skin is having goosebumps again because I am so excited about this. It's amazing. I wish I could be there in the clinic with you guys to see all this happening because it's fascinating and incredible.
Yeah. So thank you again
Yeah,
for the invitation and for this open discussion, for your motivation, because this gives us a feeling this is important. And if anyone appreciate this, like we have a lot of feedback from our patients, and this also help us to continue and to share more and to work harder on also scientific ground of this, to give more explanations, more predictions, and even higher success.
absolutely. Well, thank you so much. And I can't wait for our paths to cross again.
Thank you, Elizabeth. Take care.
Thank you for joining us on this episode of Friends with Fertility. We hope that you found the stories, insights, and tips as inspiring and informative as we did. Remember, you are not alone on this journey. Your friends with fertility are here for you. If you've enjoyed today's episode, please subscribe, rate, and leave a review on your favorite podcast platform. And don't forget to follow us on social media for updates and more fertility resources. Until next time, stay hopeful and keep believing in your journey, and know that we are sending you lots of love.